Welcome back, Health Impact audience. We had a really nice session a little while ago talking about how to get rid of the stupid stuff. And you guys heard a lot of discussion there and a lot of good questions and answers around that. One of the things that happens in us, especially where we're going through this reimagining of what care will look like over the next few years post-COVID. Of course, we're not post-COVID at the moment, but as we're starting to think about this, is that hybrid healthcare is here to stay. And if hybrid healthcare is here to stay and we don't want to do stupid stuff, that starts primarily with our staff, our workforce. So a lot of us are always thinking about, making sure we go through an evaluation process to make sure that we buy the right technology. Is our hardware correct? Are we making sure that the software that we buy is inexpensive, and can we install it? Can we deploy it? Can we integrate it? However, the most important part of any technology are the humans that are operating that technology. So for example, if you had a pilot, as good a pilot as they are on a Cessna, you put them into a 747, they will not be able to fly that plane. Just because they're a pilot who knows how to fly a plane doesn't mean that they can fly all kinds of aircraft. That's exactly how hybrid healthcare works. If our staff was trained in the past for doing a little bit of telemedicine, with a little bit of phone calls and a little bit of in-person, and then now all of a sudden we're doing a lot more of each one of these, a lot more with medical devices integrated, a lot more of digital. We know that that's not a good thing to do without making sure that our workforce is staying up to date with us. And that's why I'm really excited to have this conversation with John, Kimberly, and Colleen is, what are we supposed to do with all of this hybrid healthcare that we know is going to stick around, but we haven't had the time to actually retrain, upgrade the training, or do continuous education for our workforce. So with that, let me go ahead and have Colleen introduce herself, then Kim, and then John, and then we'll jump into the questions.
Hi, I'm Colleen Lyons, and I work for Northwell Health. I am currently the site CIO in Manhattan for Lenox Hill Hospital, and I've been with Northwell Health a little over 7 years at this point. So I'm looking forward to participating in the panel today. Always good topics, and I enjoy it. Thanks.
Awesome. Thanks, Colleen. Welcome. Kimberly.
Hi, I'm Dr. Kimberly Noel. I'm the Deputy Chief Medical Information Officer and the Telehealth Director at Stony Brook Medicine, also New York. And I lead a lot of telehealth implementation and education, our first educational curriculums for our residents, medical students. I'm also an advisor to the American Telemedicine Association and the Association of American Medical Colleges.
Excellent. John?
Hi, I'm John Kravitz. I'm the corporate CIO at Geisinger Health System. I've been with Geisinger about 11 years and very much engaged in all things with telemedicine, all services that we're providing in this new environment, and really looking forward to this discussion today. So thank you for inviting me.
No, welcome everybody. And the reason why we picked the speakers that we did is you have Colleen, very operational, day-to-day type of work. You've got Kimberly, who's also operational, but she's teaching what the next generation is supposed to know. And John really has a great deal of similar experience, but is coming from an integrated delivery network. So they have a little bit different view on, how reimbursement should work and how do you pay for things. So we have a nice mixture here. And Kimberly, just because you get to pick people before they get into the quote workforce, tell us how is education going to look different in a couple of years based on what we've learned in the past year with hybrid healthcare?
Yeah, I think education is already different. You're starting to see mandates just from the pandemic alone. Residents were a significant workforce and are addressing the pandemic and interfacing with patients. And we had to think about PPE preservation, protective equipment, and how we can get residents to practice telemedicine as well. So the new regulations with CMS allowed for indirect supervision, things that helped get the residents up and going. But to answer your question, so there's programmatic changes that have to happen at the curriculum level. But we know that in order for attending physicians to supervise properly the residents, the whole clinical workforce has to be trained. So we're actually in development of those resources right now. I am part of the Reimagine New York, Governor Cuomo's initiative to create a telehealth education portal that is now live so that we have free, open access, peer-reviewed education. That's a collaborative of over 30 organizations. So we're happy to get started, but there's a lot of work to be done.
No, for sure. And Kimberly, can you expand on that education portal, as it were? Is that good enough, or is that just like a down payment towards a lot more major changes that we need to make on the education side?
Yeah, so it's the start, right? It's the beginning. The first part is how can we get the ethos of visit is getting our best and brightest. We have a partnership with the New York State Department of Health and the Northeast Telehealth Resource Center, who've been training clinicians for decades on this material, and we're working collaboratively with a lot of large academic medical centers as well as community partners to make sure that the education and the lectures are there. So we're not recreating the wheel. At this point, everybody needs to understand what is telehealth, what are the different modalities, and how do you get started. But from there, we need a lot more hands-on training. We're introducing remote technologies, remote auscultation, like digital stethoscopes, things that are next level that need to be protocolized and developed standards around them. And so it's only the beginning, and it's a collaborative work.
Excellent points. So Colleen, if you can talk about what you guys are doing, especially on the operational side for workforce preparation enhancement, and then if you had to give some guidance to Kimberly at the earliest stages, what would you like to see her putting into the curricula, et cetera, so that when team members show up at your hospitals, they're ready to actually execute rather than need further training? So just what are you doing today to expose more and more training to the workforce? And then how would you suggest that be improved through Kimberly's work?
Yeah, I mean, those are great questions. I think, like everyone, we've learned a lot during this year. And, I think more and more what we realized too, when everyone started becoming remote, you had, administrative people, you had clinical people, you had your IT people, and it's those same questions, and you're just removing it to now be remote. Like, everyone doesn't have the same computer skills sometimes, and that became more apparent when people were now remote. The questions that were asked or the tools that they needed, everyone was pivoting so quickly, and then you realize, like, oh, well, wait a minute, that's great. We have providers remote now, but where are the reading stations, the diagnostic quality reading stations? They're at the hospital still. Yet we gave them a laptop, they can get to their systems. So, those are some examples. And then even administrative folks, the same things like, well, how do I forward my phones if I'm at home? The phones are still at the hospital. So these are just some real, generic sort of issues that happened when everyone all of a sudden literally picked up and went home. And yet then you still had, your hands-on clinical people that needed to be there. And how were they being interacted with the remote workforce? So, it was, and it still is, a lot of challenges to find that balance of how do you do that? I think for people that get onboarded, I think, I think each day we get better with coming up with different procedures to get people onboarded. Again, when you're new and then all of a sudden your exposure to a new organization is like all remote, it's hard. You don't feel that culture, you don't feel the building, you don't feel the people that you're surrounded with. So it's hard to imagine, like, hey, how's your new job? And it's like, I guess it's okay. Everyone seems nice on Teams. But yet, that feeling of, being together, I think people are missing. I think at the beginning too, it's like, all right, this isn't so bad. I've always wanted to be at home and I can still do my job. But I think now we're all realizing there's still pieces that are missing from the job. And a lot of that is, like we all say, even just with our own families and socialization right now, you still miss people. We're people and we need to be around people, not just doing what we're doing. But as we said, earlier, I think the hybrid of what that right mix isn't a bad thing. And I think we all know as well, all of us probably in our organizations were working towards these things, but we probably had the infamous roadmaps that were like 2 years down the line or 3 years down the line. And it was like, boom, we're doing it now. So I think to go forward, it would be more about really trying to bringing people on board. How do we really acclimate them and give them expectations of what that hybrid model is going to look like, to give them a comfort level that they really are, you know, part of the culture and part of the organization. And how do you get people to really feel that in the environments that we are now in? I think is the best I can, in our experience, realize that we're trying to make better for everybody as well.
Sure. And yeah, a lot of that makes sense. And if you think about the tribal knowledge aspect, tribal knowledge remotely is kind of tough. So what do you think, Colleen, based on what you're seeing, and you're still in New York, which is, you know, generally a blue state, things still look very similar to the way that they did 6 months ago. What is changing, and just the glimpses that you're seeing of the changes that are occurring, what do you feel you don't have to worry about training? For example, the point that you made about them not having basic computer skills could be something that when people are back in the office, things can be improved. But other things, you know, probably are going to stay. So what mixture stays and what doesn't stay when you're thinking about how to keep the workforce trained?
I think what stays is a lot more e-learning, to have that always be a supplement, that the in-person training and orchestration of that sometimes, especially for clinical applications, you know, to find the right time slots for providers to get trained in new systems. I think it's always because that balance of they're taking care of patients and, you know, oh, I'm available, you know, either late at night or early in the morning. If you have the e-learning being a supplement, it could be done that you're not trying to orchestrate lots of people at the same time. So I think we have found that through some various situations this year for, you know, some scheduled projects that we were still able to work on, and to work with vendors now, because a lot of the vendors for clinical applications, it's always been we need to be on site. We need to be, you know, seeing the clinicians use the systems. That's always been the mantra. And also the providers, I need someone elbow to elbow with me to get me through, you know, the training in the first few days of using it. I think that's changed, and vendors didn't have a remote model. We definitely have seen that in the last year, and, you know, still the concerns of all the changing rules. Like, you know, I don't think any of us right now can tell you what the rules are for travel, even if you've been vaccinated, if you want to go from New York to Maryland, or, you know, in regards to, hey, can this person come on site for a few days and then feel like they can go home and go about their business? And I think a lot of vendors right now are still not erroring, that's the wrong word. They're accommodating more on the side of their employees to say, we're going to try to continue to do remote so we don't have to worry about all those rules. Because I think they're still very much up in the air, and different interpretations of all of that. Like, I wouldn't be able to answer that if I can even, you know, go to the Bahamas for a long weekend with my vacation time and I come back and I'm vaccinated. What does that mean? I don't think anyone has a real answer for that quite yet. So, you know, right now I'm not going anywhere because I want to feel like I can still be at work if I need to right now, in my role. So I think a lot of that, the e-learning would be big, and also too, to get clinicians that, like, before the mention of, like, you know, the digital stethoscopes and things that can be remote. I think there's still a lot of clinical tools we have to figure out, not just a telehealth session with the viewing, but what things will people need remote that they still need to have access to take care of patients. And those are things we're still working on. I think there's a lot of gyrations of that still, and thoughts with the technology. And like you said earlier too, the idea of, just because maybe a new technology exists, you know, is it the right time, the right place in your organization to use it? If it's not integrated with the right things, it makes sometimes the workflows worse than better.
No, that's exactly right. It's a great observation. And so, John, a couple of comments from you would be great on both what Kimberly and Colleen just shared. Is number one, if you can talk about what specific things did you do at Geisinger with respect to workforce, whether it workforce prep, workforce education, just keeping the workforce aligned with all of the changes that are occurring have to be tough. And then a comment then on what do you think stays and does not stay, and then we'll pick up from the education part after that.
I think it's a great question, Shahid. I think the workforce, as abruptly as everyone else has, in 2 days, we flipped to 10,000 people working remotely, all through all sectors. And we only have like 26,000. So that was a big chunk of the people supporting that. And we do a lot of other services because we do a lot of managed care population health management. So those kinds of services in the home setting is a little tricky. And, telemonitoring and home monitoring and things like that are feeding information back into our electronic health record and making it actionable for our clinicians to be able to provide those levels of care without people being out in the home all the time is really important. We've done a lot of e-learning. In fact, as Colleen had mentioned, we put up Teams during the pandemic. We were on Skype before that on-prem, and we started moving to Teams during the pandemic, which was no easy feat to do that. And we've migrated completely out to the cloud with all of the Office suite, which has been really, really good. Really important for us. It's been a great tool because it's made it almost as realistic as being at home, which we've all seen, I think, to a great degree. That's helped. But the factors that Noel or Kimberly and Colleen had both mentioned, I apologize, Kimberly. The human factor is so important. We are humans and we need to interact with humans. And I think that's an important factor as we start to think about, for us, it's after July 1 is what we had a tentative date. It was supposed to be April 1, but we pushed it to July 1 because we're so uncertain. This was before the vaccine was even becoming available. And the vaccine's been slow to roll out. So it's probably a wise decision for July 1. We will look at, certain, like I'll be back in the office. My team will be back in the office as senior executives for IT. And we've always had probably about 9 or 10% of our workforce has been on-prem because it had to be on-prem to support the users, right? They had to be there all the while. And so we'll be bringing back more and more people. Still for IT, about 60% of our staff will remain working from home full-time, which I think may still be too high. Honestly, I am not sure. So we are looking, we've closed down a lot of our lease buildings as others have done, right? We don't need all that lease space now. We don't want to sway too far one direction or the other. I think we have to find that equilibrium for the optimal support and the optimal mental health for our employees. I think that is the important thing, in my opinion, that we really need to look at. I think those are important factors to consider. We will be doing hybrid office or hybrid cubicle space for people that want to come in a day or 2 or 3 days a week. Actually, I think that would probably be the best scenario. They could still be at home and come into the office as they need to do their jobs for meetings in person, or maybe it's a mental health break, right? It could be a good thing for them to do that. So those are factors that I think are really, really important. I did mention a lot of our work, like everyone else, we did about 1,000 telemedicine visits a month before, and we went to about 4,000 a day during the pandemic. We scaled. It was good. We felt we were planning for our network infrastructure to scale. We were pretty confident in that. And then I started sweating bullets when we had to do it because you think everything's perfect and then something's going to go wrong. But knock on wood, we're very fortunate. Our planning did work out for that purpose, and we were able to scale. We also started using a lot of bot technology, which a lot of people have been doing too, to assist in a lot of those functions. But I think, in this new hybrid environment, we're going to see more, not necessarily just bots, but using deep learning, artificial intelligence to do job functions over time. We're very much excited about that, only because we're going to be dealing with less people in our workforce available to us. And while it's beneficial to work from home and you can recruit people working from home, I don't think we're going to have the alliance to our organization that we've had in the past with all these working from home all over the country or in other countries connecting into us. I worry about that. How do we rebuild that culture? I think that is a big challenge ahead of us that I know people in human resources and other areas are thinking about, executives are thinking about, but I'm really concerned about that because I think it will become more of a transient workplace, jumping to the highest dollars, not necessarily the love of the culture of the organization, loving your leadership team, wanting to work for them. I think that's going to go out the window. So we're going to have to find new ways to create that stickiness of staff to us, over time.
That is such a great point. One that we don't hear talked about much, which is the fundamental shift in how, I mean, we already know that, nurses, I think, have the either the number one or after doctors, but it's like their fight between number one and two as the most trusted people in the entire community, not just in healthcare, but just in the entire community. If that, and that often occurs because they're tied to specific institutions that people also trust. And if that transient starts to occur, like we call this in the non-healthcare space, we call this hoteling, where you can go to one office versus another. And this happens a lot, with things like WeWork, et cetera, outside of healthcare. But we see it very quickly happening both in healthcare as well as outside simultaneously. Now, the question becomes, if you've got hoteling, you've got this transient workforce, et cetera, what fundamental shifts are different now that we have to hire for, and what is unique for hybrid care? And Kimberly, maybe start from the beginning is, what are you guys teaching that is specific to hybrid care that you would say, look, I wouldn't even be teaching this if it wasn't for the pandemic and it wasn't for this accelerated pandemic environment. So what is unique that you might be working on? And if it's not unique, did you have to accelerate it because of the pandemic? And maybe let's start with that. And then I'd love for Colleen and John to come in and maybe provide some guidance about one very specific area about education. And that is, how much can we actually teach the staff that is already well experienced in it out in the field versus there's really not much you can do with them. They kind of just have to retire out and you have to focus on the next generation coming through. So if you want to comment on that second part later, that's great, but that's where this question is heading for. So if you could just tell us a little bit about what is unique about the current instance that caused you to change the way that you educate would be a good place to start. And you're on mute, Kimberly. Yeah, go ahead.
Start talking about this because I think it's so important. So I think people are already discussing the difference between the virtual space. How does one create a culture of affinity? How do you overcome these challenges of building a team? And so some of this is unique to the virtual space, but some of it is not. Having fundamentals in communication and building an ethos of trust and ethical practice. These are things that we teach our clinicians now, but it becomes that much more imperative. We're so much more astute to the detail when we're in the virtual space, right? Try to be 5 minutes late for a virtual meeting or not be engaging in communication. It's detrimental to that safety bubble. What we have adopted, the Association of American Medical Colleges, the AAMC, have put forth new competencies that are meant to guide clinicians from, entering residency to advanced practice. And I encourage everybody to look at those competencies because they address the key issues that I feel are essential to the future. Notably, starting with patient safety. How does one escalate care? When you're talking about delivering care, the beauty of having a clinic is that if a patient decompensates, you have your CPR kit, you have that. But when you're thinking about the virtual space, just basic things of confirming a patient's location, discussing the contingency plans for technology failures, making sure that there's an adaptive way can increase the safety of a broad range of clinical practices. I myself have taken care of patients who would not go to the hospital, and I found that they had an acute airway. We had to get them, to critical care. And because of telehealth, we were able to deploy an ambulance. Less than an hour, the patient was in the critical care ICU. So, it's not that telehealth can only be used for this or that. It's really how do we train people to think ahead? So patient safety, communication being a cornerstone. There are things to what we call this website manner, being able to engage with the camera, having proper lighting, having a purposeful cadence to language, things like that we do through simulation training. So this is, again, not new, but in the virtual space, that much more important. And I can go on, but the key that I don't want to miss as well is there's also domains on health equity. How are you explaining and addressing the patients where they are in their digital literacy and not leaving them behind? A lot of people are not making the efforts to get people, in video. It's easier to pick up the phone. The phone is an important lifeline for those who really have no access or internet challenges. but we also have to start thinking about a high quality virtual service. And so those are the kind of factors that I've started to work with, but we're at the infancy. We have to start doing evidence-based studies to try to evaluate the effectiveness of training. And, but first and foremost, that's what we're starting with.
And which of those, Kimberly, are the most difficult that you feel? Is it the equity part, or is it the fact that you can't train this unless you put people out and actually do the work? Like one of the things that you mentioned earlier was that as the pandemic hit its stride, as it were, then the residents who would not be doing as much as they are today had to do a lot more. Was that hard, or were they like, yeah, we're already doing 900 things, we can add 100 more? Where did that fit? What was the most difficult part of the training that you see over last year that's changed?
So when I think about the pandemic, it wasn't necessarily the residents. Residents are usually very tech savvy, and they are amenable to trying new things. They want these new skills. We had 660 physicians privileged overnight to practice telehealth at the peak, and those are all practicing physicians. And I think what helped in that transition was having a common education, the common questions answered up front, and to guide people as to, you counsel patients well in person. This is, 90% of the diagnosis is the history. Feel comfortable trying this tool. And I think that really did help bring us up to speed. Also for people's self-interest, that they didn't want to unnecessarily be exposed to the virus if they themselves could adopt this tool. So, to that end, I think that you do need to have, common education, a very supportive environment for people to come as a resource for their questions. And then they need to try it. They need to, and that's really how medicine is taught. See one, do one, teach one. That's the kind of mentality that we brought to fast adoption as well. And we saw really novel types of teams formed. The medical students, for example, they couldn't be on site, but they could help virtually get a patient onto the virtual appointment before the appointment started and answer the patient's questions. And then we started to work on three-way video, all of these new adaptive things just to make the day go faster. And there was a very fast curve.
Excellent. Colleen, so we've got a couple of minutes before we open up to the Q&A for the audience to jump in. Could you talk a little bit about what different tools and technologies you're buying now, which might be different only because of what you saw was hard to pick up from before the pandemic? So for example, if everybody was in the office, certain kinds of technologies would have been perfect to buy, but now you're not going to buy those kind of technologies and you're buying something different because of hybrid healthcare. Can you think of anything like that? And these kind of things come to mind is you wouldn't have accelerated home-based remote monitoring in the same way that you would do today, because before virtual was two-way was fine. Even if they didn't have a diagnostic device, you could ask them to come in. Are there any kinds of technologies that you are not, or maybe depressing the purchase of and increasing other kinds of purchases because of hybrid healthcare being so much more difficult to pull off with the workforce?
Yeah, I think a lot of it right now is, maybe for every person, we didn't necessarily have something that they could just take from their office to bring home. So, just from a strictly, what do I do, 80% of my day, if I'm doing healthcare or IT work or administrative work, we definitely have shifted to, the laptop versus the desktop workstation. And there was still a lot of reluctance to that. At first, everyone wanted both. Like, what happens when I come in once a week or twice a week? What's going to be on my desktop? And, that's the laptop and a docking station. And then we'd had clinicians, and rightfully so, like, well, when I'm in my office, I have a diagnostic reading station. I need that when I'm doing that at home. So, those are expenses that weren't necessarily, thought about very quickly, right? One day we're all doing what we normally do, and the next day we're in a pandemic. like everyone said, moving thousands of people home. So, there was definitely, those types of items that we had to figure out quickly. Some of the technology that was mentioned, we were a WebEx site, we went to Teams. So, teaching people that quickly, there was definitely learning curves. But I think, other things too, like, hey, I don't have a work phone. Now I need a work phone. I don't want to be doing this on my personal phone. Or how can I do both on my personal phone and work phone that makes it seem like that they're separate still. So there was a lot of different things that we had to figure out quickly. But, I think the one big thing was more trying to make people very mobile with having, one, and it was, the stretch of, having people understand one device can do that for you, that you don't need one in your office. You don't need one in your private office over here. When you come to the executive space over here, or you're at home, it's hard now. People now have to, move with their device. And that's maybe something that a lot of people weren't necessarily accustomed to. And I think too, in this past year, people have become more accustomed to that, but they're still, you're used to what you're used to. And I think the longer people have been in the workforce, like we've talked about, even when we put the EMRs in, like, 8-10 years ago, there was the people that, are used to writing their orders, and it was hard for them to adapt. Now you have the opposite issue with the younger workforce, like when the systems are down, even for an insignificant amount of time, they're like, I don't know how to write an order. I need a computer. So it's all of, it all sort of always intertwines. It's just so interesting. And I think we need to give people a lot more credit for when they were in the middle of this and nervous. I can't do this. I can't do this. But, you do form your little remote groups and people that would say, I can't do this. I can't do it. Well, guess what? They're doing it.
Yeah.
And I think they realize, like, if I really want to do something, like we all say in life, if you really want to do something, you can teach yourself, or you can focus yourself, and you can do it. And I think people have impressed themselves as well in that manner.
You're right, Colleen. We have shown that healthcare is far more resilient than we ever thought it was. And the staff, because they care, right? They are able to elevate themselves. So John, with the last minute we have left before we open up for Q&A, so Geisinger is an IDN. There are ways that you can spend money on staff, et cetera, where you don't have to apply it to reimbursement, specific claims or DRGs, et cetera. Have you guys learned things with respect to how you are training your workforce as an IDN, which could be applicable to also non-IDNs or people who do have to worry about getting that paid for through claims and reimbursements? Or do people really have to start moving to more value-based, and it's going to be a struggle until we get there?
Well, I think, Shahid, I think we got to move to value-based medicine. We need to do that because as a country, if we don't, our GDP is 18%, encroaching 19%. That's not good. That's not good for our economy, period. So, some of the initiatives that have been underway in the last administration, like price transparency on pharmaceuticals and things like that, really important. But, we need to do things differently than we ever have before. We need to reduce the cost of things where we can reduce the cost and not impact quality or improve quality. That's the really the important thing here. If we can increase quality, reducing costs, that's the perfect scenario for us. And to that end, what we've done is we've adopted a migration to the cloud strategy so we can be more efficient in what we do. And I'm actually in a planning phase right now for the migration of my data centers to the cloud, right? That's where I'm going to go as a whole. So to the point of your question to Colleen was, new software coming in, ours, if it's not cloud, if it doesn't run in the cloud, it's not considered. It's just not going to happen. And so, because that improves things all the way around, right? We used to use Skype, for our conference calls and things like that. We had to come back inside the firewall and back out to people working home. Now they can authenticate right to the cloud. It's one point and they can connect to it, and it's cleaner. It's worked better. So we're looking at that. Cloud is good. Cloud is tricky. Cloud security is important, really important. So everything we look at is, okay, if we're looking at a new application, we beat it to death for cybersecurity. We make certain there's no holes. We just literally look at that to the nth degree for quality and for cyber protection for us as an organization. So that is our direction going forward. I think it's really important and imperative for us. Moving to the cloud is another tricky cyber scenario for us with a lot of the data loss prevention, CASB, other things for authentication purposes. Things like that are really, really important. And we can't take that lightly, but it is the transition of healthcare. How do we reduce our costs and get better at what we do, providing a better service? And when we retire things, those costs all go away all at one shot versus hanging around for 4 or 5 years while you depreciate hardware, right? Or other assets. It's a pain. So that's part of our challenge moving forward, but we're keyed in on it, and we're going to be successful at that.
That's great. And you guys have already seen a lot of questions coming through on the chat, so that's great. We're going to pick up that in just a second. For any audience members that would like to come on camera, this is a good time to do so, or just keep putting your questions within chat. I want to thank John, Kimberly, Colleen for spending some time with us on this very important topic of workforce, and we'll hand it over to the audience now. Thanks a lot.
Thank you.
Thank you.
Thank you.
All right, great. So as you guys saw, there was a nice lively chat going on, and I thought I'd pick Stephanie's question first. She asked, my challenge is being able to hire outside of the state. Our legal and HR teams have concerns about opening this door. Would be interested in how others have addressed this. She has a pretty acute problem because she's in a small population state, and so it's very important for her to be able to hire outside. What are you guys doing if you'd like to address that? Colleen, if you have anything, we'll let you start, and then let Kimberly and John answer as well.
Yeah, I mean, it's a great question. We definitely have had some of the, I know specifically firsthand, some of our IT workforce has moved to other states. And I think all of those questions that you have concerns about, we still do as well, like, taxes, being in New York, typically we're in an area that, pays high salaries because it's a high cost of living. So now people moving to maybe states that don't have those cost of livings, do you adjust salaries? And do you have a tax ID in those states? I think a lot of those things are still being worked on, even as people say, I'm moving to New Mexico, I'm moving to Pennsylvania, because we definitely have had those things, not maybe as much as we thought, but we definitely have handfuls of folks that are making those permanent moves. So I think that's still a work in progress for us as well. It's definitely a challenge as to how do you address that.
So speaking of Pennsylvania, John, we'll let you go next.
Sure. Thank you. We have, I've actually in IT, I probably have people in at least 10, 12 different states, West Coast, South, all over the place. And my person that runs my data centers is based in Miami. So it gives you an indication of how effective you can be at that in our enterprise command center. So yeah, we have a lot of that. Now, we're not in every state. And as Colleen had mentioned, we need to have the tax IDs and things like that. We've just gone live with a new human capital management system with Workday. And I think that's been a factor for us as far as where we recruit. But I don't think it encumbers us from recruiting in other states. I think it's more of a coordination factor, working with our human resource folks and people that are engaged and interested, because I see this happening more and more where more jobs are remotely supported and working very effectively. So don't anticipate this changing. In fact, we'll probably be looking internationally more. That'll be challenging because of the time zones, but I think that's going to occur as well in our new workforce model.
Interesting. So, and before I bring Kimberly in, could you talk about the difference between credentialed type of staff versus, like on the IT side, we don't have to be credentialed and we don't have to have licensure. Has that been an issue for you guys?
It has not been an issue for us, although I do require a lot of my staff to be credentialed in other ways, like IT service management and other things. We're certified in, support of our electronic health record platform with Epic. So we do a lot of that anyway, although it's not formal medical credentialing. We still do require that for a number of our positions. So we know people are, very much qualified for the work. Even though you go and do a great interview with someone, at least they have the experience behind them.
Right. And Kimberly, should any of Stephanie's legal and HR teams be worried about sourcing outside the state?
So I think actually in the last session, Adam Landman had just brought up the importance of national licensure. Because a doctor who's trained in one state practices the same medicine. We are boarded through national organizations. State licensure is prohibitive to continuity care. So I very much support that. And I believe that needs to be a policy change. And I also feel that there are many ways to assess skill remotely. And so I think remote work is here to stay, and we need to fill gaps of care. Telehealth can be an amazing democratic tool for access and to reach areas that are underserved. So I think that this is something that really needs attention.
Right. And related to that, can you also talk about, you had put in a note about especially a link around the telehealth training portal. I'm wondering if we can start putting more education materials about this kind of stuff, about licensure and working across state lines, so that these discussions become normal part of everyday work that we're doing, enough to where it starts to impact and people start asking their policymakers, public policy type of folks, because it may not be being asked enough. As much as we complain about it in these kind of circles, maybe it's not being asked enough in the right circles. Where should that occur, Kimberly?
I think it starts with the state, at the state level, because licensure is, ordained by the state. So you see a lot of governors taking this as a primary policy, as feedback from the COVID pandemic, and I think there's a lot of work that still needs to be done in that space. So we also have to think from physicians. If I'm not licensed in a state, you have employees who have moved across state lines, but you also have patients who've moved across state lines. And technically, if I'm practicing telehealth in a state where I'm not licensed, I'm putting, my profession at risk. So, and that creates abandonment issues of the patients that had to, move from the pandemic. So I think that this is a much bigger issue. I think it starts with the states, but that there needs to be also federal action.
Yeah, makes sense. So another couple of notes that were put by John and others is how to allowing remote worker culture to stick. And John mentioned its biggest problem. They look at creating events to make remote employees feel connected to the team. Colleen and John, do you want to talk about how you guys are trying to make the teamwork work across these sessions? And maybe John, since you're doing so much more of it, tell us how you're keeping the teamwork working.
Well, I think, the biggest factor for us is getting the team to feel engaged, especially new employees that come into the organization that are remote workers. How do they feel connected to the other people? It was different, pre-March of last year, when people could be welcomed, they could be part of meetings, get to know people, look them in the eye face to face. Yeah, they could look them in the eye on Teams, but it's just not quite the same when we're across the desk from each other and sharing personal stories and things of that nature. So I think those are important. So we try to find other ways. Other folks had great ideas with gaming and other things that could be really beneficial. We've done just staff huddles at the end of the day on Fridays, and it can turn into a happy hour, provided it's after 5 p.m. and everything's legit for company policy. But it's a time to unwind and share personal stories with people and do things that are different. A number of my teams have done that. Especially the large teams like our electronic health record team and others have done those kinds of things. And really, it's been very positively received. So I think we'll see more of that over time. But we just have to get creative. We used to do offsite retreats with people together. No reason we can't do that after the pandemic subsides, and I think we will. Even if they're working remotely, get together. Just, get off for a picnic in the afternoon, take an offsite retreat, do some fun, activities. I think those are important things for us going forward that we really should not discount.
Yeah, that's a great point. And unfortunately, we're out of time. So I want to thank Colleen, John, and Kimberly again for coming on live with us to talk through the last few questions. And just as a quick reminder, if companies like DoorDash, et cetera, are delivering for meetings, right? So you can actually have a meeting and have food delivered to people. I think that part is still possible remotely as well. So hopefully we'll cover some of that in the rest of the sessions coming up as well. But thanks again. Please join us at our next session. Just click the speaker portal button, your portal button, and then go to the next session from here. Thanks, everyone. Bye.
Thank you.